Actually, the topic given to me by Dr. Nita was reversal of diabetes. Is it possible without surgery? But I thought remission of diabetes with lifestyle modification, and then I'm going to be a couple of more slides on a couple of studies that we have done in our center where we have shown that remission is possible when you follow patients for a long period of time. My previous speakers, Gita and Dr. Makar, both spoke about a lot of studies, whether it's nutrigenomics or intermittent fasting. And what we observe is nothing dramatic is going to happen unless you keep doing what you are doing. And I think that is the key take-home message even before I start speaking, because most of the studies that we speak about and which I am going to be showing you are either restricted to 6 months, 8 months, and then you are looking at remission, following it for 2 years and 4 years, typically at the phase that people are not doing what they are doing. And like Dr. Makar showed us that when people start eating after the washout phase, things reverse. And therefore, I think the concept of lifestyle modification here is that you have to not do it because it is diet or because it is lifestyle modification. You have to do it because it is lifestyle, it is good for you, and you have to keep doing the same things again and again. So to begin my talk, we know diabetes traditionally has been considered progressive and incurable condition, wherein in the best of scenario after diagnosis, tight metabolic control is possible. But we are looking here at remission, and what is remission? So we talk about partial remission being hyperglycemia below the diagnostic criteria threshold of diabetes for at least a year where no pharmacological therapy is given, and complete remission is normoglycemic measures at least 1 year of duration and no active pharmacological therapy or ongoing procedure, and prolonged remission is when it does happens for 5 years. Now, these are various intervention studies, and I know the slide is very, very popular, where we are talking about drugging, GPS, DPP, and various other studies where diet and exercise have had a much superior role as compared to, say, metformin in case of DPP, in terms of any other pharmacotherapy, in terms of remission of diabetes. So my scope of my talk is going to be first talking about remission of impaired glucose tolerance, in also remission in non-obese, because we have seen most of the studies are restricted to remission only in obese people. Also remission in obese and overweight using BLCDs and LCDs, which are so popular now. Also food-based BLCDs and LCDs, and some of our studies and experience. So we know the first study we're going to be talking is Darwin IDEC study, wherein individuals with impaired glucose tolerance having high risk of type 2 diabetes. The purpose of the study was to determine whether diet and exercise interventions in those with impaired glucose tolerance delay the development of type 2 diabetes, and it was found the study went on for 6 years, and there was a 67.7 as compared to 67.7% of incidence of diabetes in control group. In case of group with diet, there was only about 44%. In exercise, about 41%, and diet plus exercise, it was about 46%. The most popular study is diabetes prevention program. It happened over 27 centers. It was a randomized clinical trial to determine whether lifestyle intervention or pharmacotherapy, that is metformin in that case, would delay the onset of diabetes in individuals with impaired glucose tolerance. And it was shown that lifestyle intervention decreased the incidence of type 2 diabetes by 58% as compared to just 31% with metformin. And I think again this slide is very, very popular. Key aspects of DPP lifestyle protocol was, and that is very interesting, that is what makes lifestyle intervention what it is. It was clearly defined weight loss and physical activity goals. They have to be extremely clear and told to patients. They had individual case manager or lifestyle coaches. So somebody who was handholding patient all the time. Intensive and ongoing intervention, initial work curriculum to achieve standardization of intervention, because all patients have to be spoken about same thing, supervised exercise session, a flexible maintenance program where they were given a lot of options when people were on maintenance. There was an individualization of toolbox for their strategy. For example, somebody who couldn't exercise was given a, say, a gym membership. Somebody who couldn't eat healthy were given entrees which were lower in calories. So these were the toolbox. Materials and strategies have addressed the needs of ethnically diverse population because they have people from all over the world. So what was dietary modification in DPP? The initial focus of dietary intervention was to lose fat. And this was in early 2000s or late 1900s, and that is the time when fat was considered as the real culprit. Reducing fat actually reduced the caloric intake, and therefore later on there was stress on laying emphasis on caloric balance. Then there was Indian diabetes prevention program, wherein it was also shown that lifestyle reduced the risk of diabetes in relatively non-obese but insulin-resistant Indian population, and that is the patients which were in BC, which are not that obese but they are more insulin-resistant. And lifestyle modification was more effective than metformin in all races, including ethnic minority population, and the effect of metformin was lower in thinner individuals. The change in body weight was not significant, so because people were not that obese, the change in body weight was not that significant in Indian diabetes prevention program, unlike in diabetes prevention program. So this is something that we take back from these two studies. Then we all know there are DSCDs which are given to these patients, not only to lose weight but to manage sugars. And we know what are DSCDs, all diets below 800 kilocalories, and there are other details typically given to people with BMI about 27. And this is what DSCD does. DSCDs help you achieve a caloric restriction. Also because they are high in protein, they achieve satiety and therefore appetite suppression. And then of course a lot of DSCDs also when they are very high in protein cause ketosis and thereby blood sugar control. So the biggest study which happened was the pilot trial wherein there was these DSCDs which were prescribed. So there were two groups. About 5,000 people were randomized into intensive lifestyle intervention which did have DSCDs as one of the strategies and diabetes support and education group. And we found that people with intensive lifestyle group did lose a lot of weight initially, and then of course the weight loss tapered off when they stopped using DSCDs. But when they lost weight, it was found that their sugars did much better. So this analysis of more than 4,500 overweight adults with type 2 diabetes findings suggest that intensive lifestyle intervention may be associated with partial diabetes reduction in subset of patients with type 2 diabetes, particularly those who have diabetes for short duration, who have lower HbA1c, and who yet are not on insulin therapy. And as many as 11.5% patients of lifestyle intervention had complete or partial remission within first year of intervention, and 7% had partial or complete remission in 4 years. So this is something that tells us about the correct trial. And there are a lot of benefits of weight loss other than looking at just sugars, because it improves risk of CVD, improves serum lipids, and reduces inflammation. And inflammation is the biggest culprit in today's as identified today. Then there was by-weight trial, wherein this was a 12-week weight management program which advised to consume 2 meal replacers plus 2 snacks per day. And it was seen that these patients actually lost weight and they also lost HbA1c decreased in these patients. Now, this is food-based intervention where DSCDs which were made of food and not ready to drink shakes. And even in this, we find that there was a greater increase in fasting glucose at the end of a 20-week program which involved DSCDs made at home or using food as DSCDs. This is one study from India where it has been shown that in Bangalore, where patients with intensive lifestyle modifications actually were able to drop their HbA1c after 1 year of intervention. Now, these are studies of various dietary interventions in diabetes, and that is what is very interesting. What works, whether high protein works or low calorie works, and what we see is the study which actually brought in the most decrease in HbA1c was the lookalike trial, wherein you see that there was greatest decrease in HbA1c. And if you look at all the kinds of diets which were given to patients of diabetes, you will see that the diets which were high in protein caused more weight loss and better HbA1c in the short term, but because these diets could not be followed for a long period of time, like 4 or 5 years, they HbA1c increased. Now these are some of our interventions, and we know that in India carbohydrates are very high in diet, and they cause a huge PP excursion. And we know that Asians give a higher PP response as compared to Caucasians on same kind of food, and therefore PP sugars become an independent risk factor. And we have seen from study that Indians do consume a lot of carbohydrate, and therefore what we did was we had a strategy to decrease carbohydrate consumption. We replaced cereal to pulse. So what we did was we took these patients with impaired glucose tolerance, and we replaced their midtime snack or their meals with 4 cereal exchanges of cereals. We exchanged with pulse. So instead of giving 4 rotis, we gave them 4 rajma khakras. Other than that, the patients remained, they were allowed to eat everything what they were eating. And what we found is at the end of 3 months, their fasting sugars decreased, their postprandial sugars decreased, and also their lipids improved considerably, especially triglycerides. And we presented this paper at the American Diabetes Association 2 years back. Now, this is a very interesting study wherein we asked patients to actually send us what they were eating on daily basis, just advising them on WhatsApp. And they were sending pretty pictures of what they were eating and sending us every day. And what we found is that over 3 months period, they were able to achieve a drop in HbA1c, wherein we were counseling them just about portion sizes. So if you look at the portion size on day 1, you see a lot more carbohydrate in patient's plate as compared to end of 3 months where patients were eating lesser carbohydrate. This was technically using just the plate method of counseling, but counseling via WhatsApp. And a lot of times, because it was real time, because patients were taking photographs and sending it to us, we were able to counsel them when they were in front of food, and we were able to achieve a drop in HbA1c over 3 months. But again, here we found the same thing that the patients who were on insulin, their HbA1c dropped lesser as compared to patients who were not. So look at this patient again. They were eating a lot more carbs, a very little amount of fiber and vegetables, and we find that if that got changed, we found a marked reduction in HbA1c of these patients. So in conclusion, remission of type 2 diabetes is possible with intensive lifestyle regimen. This could include use of low-calorie diet plans or use of low-calorie diets or DLCs. Very strict dietary regimens are associated with increased compliance, and that is what we are seeing, that if we ask patients, like Dr. Markar showed, if we ask patients to actually fast every alternate day, which is very strict, shows low decreased compliance. So strategies have to be developed to ensure long-term compliance to these dietary regimens. Better recipes, and that's why I think dietitians are so important. Interesting food options should be provided as DLCs, and we have two dietitians sitting here along with me who will agree that when we put patients on DLCs, the only thing patients say is shake mat do, khana do. So that is something I think that is what actually makes people happy when they eat food rather than just drinking shakes. So I think time has come for shakes. Instead of shakes, we should have low-calorie entries which fit into the BSC protocol. And what is very important is strategies to stay in touch with patients and hand-hold them should be developed, because a lot of times patients are faced with a lot of food and they cannot make decisions there. And that's where the dietary protocols go down the drain. So I think if there is a strategy where a patient can ask for help and get help when the patient is in front of food, I think that will go a long term in maintaining a lifestyle intervention. Thank you so much for your patience.